We did it. All right, well, welcome everyone. I'm really excited to talk about cannabis and neuropathic pain. This is an area that I see a lot of success with in my patient population. So in case you don't know who I am, I'll just quickly introduce myself. My name is Eloise Theisen, and I'm an adult geriatric board certified nurse practitioner. I'm the current chief nursing officer and board president at Leaf 411, the CEO of Radical Health, and the current president of the American Cannabis Nurses Association. So in my presentation today, we're going to talk a little bit about cannabinoids and the research out there for neuropathic pain, and whether or not that research supports cannabinoids for the use of neuropathic pain, and which cannabinoids are best for pain and inflammation. So we currently know that about approximately 1/3 of the US population is suffering from chronic pain that is debilitating. And as we mentioned in our opening, we have about we have in 2017, the National Academy of Sciences came out with their report on the health effects of cannabis and cannabinoids. And it was a very comprehensive report. It already feels a little out of date, to be honest with you, looking back at 2017. But what they found in there was that there was conclusive evidence that cannabis or cannabinoids are effective for treatment of chronic pain in adults. And in fact, they found that CBD and THC were shown to be effective at reducing inflammation, modulating pain, boosting opioid analgesic effects, and shifting the dysphoria associated with pain. But yet, despite that information, we still aren't recommending cannabinoids for chronic pain as a first-line therapy. But there's quite a bit of research out there specifically in neuropathic pain. And in 2017, there was a review of over 100 studies of commonly prescribed medications for diabetic neuropathic pain. And the researchers at the Hopkins group found that only moderate evidence for the efficacy of these antidepressants like duloxetine, venlafaxine, and weak evidence for the efficacy of botulinum, so that's your Botox, pregabalin, oxycarbazepine, tricyclic antidepressants, and atypical opioids. In fact, we even found some evidence that cannabinoids can enhance the effects of gabapentin and improve neuropathic pain relief when those are used together. So we know that a lot of these medications aren't necessarily going to be effective, yet patients are given this as their first-line therapy. And we also know that glutamate, when present at excessive concentrations, contributes to neuropathic pain. So CB1 receptors will play a crucial role in preventing the neurotoxicity caused by the release of glutamate. Cannabinoids that are CB1 agonists might inhibit glutamate release and help alleviate neuropathic pain. In many commercial markets, delta-9 THC is the only CB1 agonist available. And we know that things like Marinol, which is dronabinol, or Sesament are CB1 agonists as well. That's our FDA approved. And in mature commercial cannabis markets, however, considering using products with THCA, CBN, or CBC, all of which are partial CB1 agonists. More research out there, cannabis reduces pain and sleep disturbances in patients with multiple sclerosis. We've seen some pretty significant data to support, specifically clinical human data to support that cannabinoids are effective in treating neuropathic pain associated with multiple sclerosis. In fact, a lot of those studies have been with the use of Sativex, which is a 1-to-1 CBD to THC oral mucosal spray. It is currently approved in 33 countries, but not the United States. And Harvard actually put out a review because one of the things we hear often is that there's not enough research. And particularly in chronic pain and in neuropathic pain, we do have, again, conclusive evidence. The reviewed literature included 24 randomized clinical trials of cannabinoids for pain. And in those trials, we saw that there was 325 patients in these 6 trials with chronic pain, 396 patients with neuropathic pain in 6 trials, and 1,600 patients who had multiple sclerosis were included in 12 trials. So we do have significant research. I love to show this study here particularly because I find it fascinating, the actual doses, which I didn't list on here, that they used in this study. So this was a THC vaporized cannabis study in humans. It was a very small study, 42 patients who had spinal cord injury, and they did complain of report neuropathic pain. They were using between 2.9 to 6.9% THC in their vaporized cannabis. So very low amounts of THC. And I think if you were able to join us with Dr. Sulak's presentation, he talks a lot about using the lowest possible effective dose. And so a lot of times our patients and seeing these high numbers of THC, and the percentages of THC don't necessarily correlate with outcomes. So we don't need to be encouraging our patients to get the highest THC possible. We really want to look at, again, many compounding factors before making our recommendations. But this study really demonstrated that low dosages were significant at relieving their pain. And you can find a lot of research through Cannabis, and Cannabis is something that will help facilitate access to published science, and they use aggregated clinical data points, and this is really for clinicians. So if we look at peripheral neuropathy, for example, we can find that there's 28 primary studies and 14 related studies. So the primary studies focus specifically on cannabinoids and neuropathic pain. 8 of those were double-blind human trials, so again, some good data there. And then 3 were human clinical trials. And this Cannabis does a great job of providing any clinical dosing data that might be available, because of course, as clinicians, we're always wanting to know how much, how often should we be giving. And this is an area where it can be not only individualized, but where we can be lacking some of that data. You can also see what kind of chemotypes they use. Is it high THC? Is it a combination of CBD and THC? Is it high CBD? And over here on the right, you can actually see here the different studies that are available, the year it was published, and details. When you click on the details, it will actually bring you to that study. And if there's open access, you can get it there, or you can, of course, try to access the full study otherwise. But great information for us as clinicians who really want to be evaluating the evidence in these specific areas of cannabis. So of course, understanding the benefits of each cannabinoid is really what's going to help us identify which cannabinoid profile is most appropriate for our patients. And there's just thousands of different cannabinoid profiles out there. People call them strains. We want to move towards that term of chemovar, or chemical variety of cannabinoids, to help us really identify the different cannabinoids and terpenes to match our patients' needs. So of course we have THC, and THC can provide pain relief through a number of different mechanisms. And most of the research has been on delta-9 THC. Many of you may be starting to learn about delta-8 THC, which has certainly made a name for itself in the last few months. But specifically with delta-9 THC, which we know is responsible for that euphoric effect, it can lower blood pressure, it can reduce inflammation. As Dr. Sulak was saying, we know that it's an anti-inflammatory and an analgesic, and it can block some types of pain and possibly impact obesity and diabetes. It has great therapeutic potential, but is often not really used as much as I think it can be, because people get a little bit nervous about the euphoric effects of THC. But similar to CBD, THC can help opioids work more effectively. And Dr. Sulak was really presenting that great information about that synergistic effect. So when we get that synergistic effect, it can enable patients to achieve efficacy with lower doses. And that helps reduce the risk of addiction and overdose. And as we mentioned in the very beginning, there's been a sharp increase of about 30% in opioid overdoses since 2019. So THC can be really powerful for harm reduction in our patients. It can also produce analgesic effects by modulating neurotransmitters relevant to the transmission of pain, such as our endogenous opioids. And again, powerful anti-inflammatory and analgesic. And it has other abilities to help other things like nausea, appetite loss, insomnia. And sometimes those can be other symptoms that our chronic pain patients are experiencing: anxiety, post-traumatic stress, Tourette syndrome, and even some cancers. And it's not a COX-1 or COX-2 inhibitor. So that means that even though it's helping with inflammation, it's not going to have the same side effects that our NSAIDs have, where it can affect our cardiac function or the lining in our gut. That tends to lead to a lot of issues when you take those NSAIDs. So again, harm reduction, much safer. And side effects are dose dependent. So our patients may be experiencing side effects at higher dosages. So when you look at this list and you see hallucinations, paranoia, amnesia, anxiety, we tend to see those in higher dosages. Now, there are some people even at low dosages that will experience those effects, and we can always add in other cannabinoids or try other cannabinoids to help avoid that. But again, we may be wanting to use some of these, these side effects sometimes may be our intended outcome. And again, the adverse effects are biphasic. So starting low and slow not only helps avoid these adverse effects, but it also helps make sure you don't avoid that therapeutic or miss that therapeutic window. And THCA may be a good option for patients who are sensitive to THC or want to avoid impairment. And it is the raw component in cannabis, and it's the most abundant cannabinoid in raw cannabis. Once it's heated, it will turn into THC. But research is starting to suggest that THCA is more water soluble than THC. So our patients can use lower dosages of THCA and achieve relief, which reduces their costs and, of course, potential adverse effects. And CBD. I know Dr. Sulak didn't get a chance to really discuss CBD, but we are seeing that it can positively influence mood and shift the dysphoria associated with pain. And it can bind to our TRP1 receptors, which modulate pain, itching, and inflammation. So initiating analgesic effects in cases of inflammation and neuropathic pains via our PPAR receptor system. We do think that CBD tends to interact with more receptors than THC. So there's a lot of research there we still can uncover. Again, it can help with opioids working more effectively, similar to THC, enabling patients to take lower dosages of their opioids. And it can help relieve that pain, itching, inflammation. It can help relieve pain related to inflammation and neuropathic pain, and it can actually protect the nerves from damage. And CBD can potentiate endocannabinoid signaling. We've seen it effective in other conditions like nausea, seizures, psychosis, neurodegeneration, cancer, anxiety, depression. You can see the whole list there on the right side. So again, some of our chronic pain patients may have additional symptoms that cannabinoids can help with in addition to the pain. And it's very well tolerated and safe, even in high dosages. And you'll see here that you can see things like dizziness, lightheadedness, tachycardia. Definitely drug-to-drug interactions is more likely with CBD than THC, but again, it's not contraindicated. Most often I see drowsiness and diarrhea with CBD. And the psychoactive effects of CBD are also biphasic, so different effects at low dosages versus high dosages. And at low dosages, I can sometimes see improved concentration and energy. And at higher dosages, we may see it helpful for anxiety and even psychosis. And just as though THCA is the raw form of THC, we have CBDA, which is the raw form of CBD, and it is the most abundant cannabinoid found in raw hemp. And similar to THCA, we're finding research to suggest that CBDA is more water soluble than CBD, so patients can use lower dosages to achieve relief, which helps improve their cost and decrease potential adverse effects. And I actually see, even though the research doesn't necessarily support that CBDA is effective in neuropathic pain, observationally in my patients, I see that it helps a lot with neuropathic pain and in much lower dosages than CBD. And we know that its anti-inflammatory properties may be helpful for arthritic pain, but it's not a cannabinoid we've studied a lot. Same with THCA, we don't have a lot of data on it. So the little asterisks there are just things that, again, that I've observed in my practice, helping with cognition, ADHD, fatigue, and even pain. And just briefly wanted to mention that CBD from hemp and CBD from the cannabis plant are the same molecule, and hemp plants can flower. So you may be seeing a lot of your patients who are purchasing CBD off the internet or in some CBD specific stores are likely getting a hemp-based product. But because they can flower, we're now using those flowers to produce the medicine, which is the best portion of the plant to use. Traditionally, we've used hemp for industrial purposes. So the stalks and stems have been used for rope and textiles and concrete. Just make sure if you're going to encourage your patient to try or use CBD from the hemp plant, that they are getting a product that is marketed as flower derived and not from the stalk and stem. Oops, where did all my stuff go? Oh, so I want to just leave a couple questions for a couple minutes for anybody that might have questions about this. It looks like I do have something here in the Q&A. What helps fight back pain or even insomnia for pain? So Jerry, not to frustrate you, but a lot of times my answers are, it depends. Usually in my patients who have chronic pain, whether it's neuropathic pain, nerve pain that can be associated with fibromyalgia, arthritic pain, I do want them to have a little bit of THC. And maybe, I might start with a CBD dominant and add in some THC depending on their tolerability. But the data really does suggest that THC is incredibly important for pain management. So most people who try just CBD for pain may hit a wall where they're not getting much more relief, and that's where THC can be very effective. And there are resources coming out, and a lot of it, like Dr. Dustin Sulak's book, is a great resource. We also had a resource through Radical Health with a protocol guide. They're geared towards clinicians to help their patients who are looking. And healer.com has incredible information on there. So if you haven't had a chance to check that out, please do. Susan asked, how do you manage patients who don't like the psychoactive effects of THC? Yeah, that can be very challenging, and a really good question. So again, it depends. I might go really high doses with CBD if they can't tolerate THC. I might do the THC at night, because sometimes even that accumulative effect of THC, even if they're only taking it at night, we can reach that steady state in their blood where they're still getting the benefits of the analgesic and the anti-inflammatory effects and not having to feel any of the impairing effects. You could consider THCA, which isn't too impairing. You could consider different routes of administration that might help with tolerability. And Debbie was asking, would you add in CBG, which is also a non-impairing cannabinoid? I haven't had much success in neuropathic pain, but I've found it can be really helpful for muscular pain. So a lot of times when people get headaches or cramps and things like that, CBG can be really helpful. So, we have so much to choose from when it comes to cannabinoids. Not in every state, of course, because it's still medicine by zip code, but there are ways to help people with the pain without feeling impaired. So I know there's a couple more questions, but this is the end of my presentation, and I want you guys to all have an opportunity to go to the other sessions. So I thank you so much for joining me today, and you can always rewatch the recording if you want to catch up or have any additional things to gather from it. So enjoy the rest of the breakout sessions, and hopefully I'll see some of you at the fireside chat, where you're welcome to come in and ask more questions there. See you soon.